Welcome to another episode from the Veterinary Medicine Digest. Imagine, if you will, a quiet examination room in a sun-drenched veterinary clinic. On the table sits an elderly domestic short-haired cat named Oliver. To his owner, Oliver is just slowing down, a natural consequence of his 12 years on this earth. He does not jump on the kitchen counter anymore, but the owner thinks that is just a newfound sense of feline decorum. He sleeps more, but they assume he is just enjoying his golden years. But when the veterinarian, a specialist in feline medicine, tries to touch Oliver's hips, the cat flinches. There is a subtle hiss, a dilation of the pupils, and a tensing of the muscles that only a trained eye would catch. This is the silent epidemic of feline osteoarthritis, a condition that is as pervasive as it is misunderstood. For years, we have relied on these subtle behavioral cues, on the subjective reports of owners, and on our own imperfect clinical metrology instruments to gauge the suffering of our feline patients. But what if we could reach inside and listen to the brain itself? What if the neurons could tell us exactly how much it hurts? Today, we are going to dive deep into a scientific pursuit that feels like something out of a science fiction novel, yet it is grounded in the latest neurophysiological research. We are looking at a study published in early 2026 in the Veterinary Journal titled Electroencephalography-based Quantification of Chronic Pain in Cats, a proof-of-concept study using the pain identification and quantification algorithm. This research aims to move beyond the subjective and toward a biological painometer. But as we peel back the layers of this study, we must ask ourselves if we are truly witnessing a breakthrough, or if we are being led down a path of statistical mirages and methodological vulnerabilities. Before we can appreciate the ambition of this new electroencephalography study, we must understand the landscape of feline pain assessment that preceded it. For decades, the diagnosis of osteoarthritis in cats has been a point of contention and frustration in the veterinary community. Unlike dogs, who often present with obvious lameness, cats are masters of disguise. Their evolutionary history as both predators and small enough to be prey has gifted them with an instinctual drive to hide any sign of weakness or vulnerability. By the time a cat is limping, the disease is often advanced. In response to this diagnostic vacuum, researchers like Mary Klink and Eric Troncy at the University of Montreal spent over a decade developing and refining the Montreal instrument for cat arthritis testing for use by veterinarians. This tool was a major step forward, shifting the focus from simple bone radiographs, which often do not correlate with the actual pain an animal feels, to functional assessments. In 2015, early validations of this instrument showed that while things like joint palpation were surprisingly unreliable, observing a cat's gait and body posture could actually distinguish between those with and without the disease. Yet, even with these refined instruments, we were still just observers. We were watching the cat's behavior and making an educated guess. In 2024, a study using a coxib non-steroidal anti-inflammatory drug called Firocoxib demonstrated that the Montreal instrument was indeed sensitive to treatment. The cats got better, their scores improved, and we could see the drug working. But we were still measuring the shadow of the pain, not the pain itself. We were measuring the functional impairment, the reluctance to jump, and the stiffness of the walk. The actual neurophysiological experience remained a black box. This brings us to the concept of central sensitization. In chronic pain states, the nervous system itself changes. It is not just that the joint is inflamed, it is that the spinal cord and the brain have become hypersensitive. The volume has been turned up, and it is stuck there. This is why some cats, even after their inflammation is treated, still seem to be in distress. To measure this, veterinarians have used quantitative sensory testing, such as measuring the paw withdrawal threshold with an electronic von Frey aesthesiometer. By applying pressure until the cat pulls its paw away, we can get a sense of peripheral and central sensitization. But even this is a reflex, a behavioral response that can be influenced by stress, the environment, or the cat's individual temperament. To truly understand chronic pain, we must look at the brain. The brain is the ultimate arbiter of what is painful. In humans, we have known for a long time that pain is not just a simple signal from a nerve to a receptor. It is a complex cortical integration. This is why we see phenomena like phantom limb pain, where the limb is gone, but the agony remains because the cortical representation is still firing. If we could tap into those cortical dynamics, we might finally have an objective measure. Enter the study by Delzart and colleagues. Their objective was bold: to take an algorithm developed for humans called the Pain Identification and Quantification Algorithm, or PEAQ, and see if it could decode the brainwaves of cats suffering from osteoarthritic pain. The premise is that the core nociceptive pathways are conserved across mammals, and therefore the brain's signature of pain should look similar whether it is in a human or a feline. But here is where we must begin our scrutiny. The study is described as a proof of concept, and for good reason. The sample size consists of exactly 5 cats, let that sink in. In a world of human clinical trials involving thousands of subjects, we are looking at an analytical pipeline built on the data of 5 individuals. 2 were pain-free, 2 were diagnosed with chronic osteoarthritis, and 1 was described as having an ambiguous pain profile. From a PhD-level perspective, a sample size of 5 is not a cohort, it is a series of case reports. While the researchers argue that their unit of analysis was the high-quality electroencephalography signal rather than the individual animal, we must be wary of drawing broad conclusions from such a statistically fragile foundation. The methodology of the study involved placing electrodes on the cats' heads in 2 conditions, once while they were conscious and resting, and once under light sedation. For the conscious recordings, the cats were placed in a mesh enclosure on a cushion, wearing a wool hat to keep the electrodes in place. Imagine the potential for stress in this environment. A cat, already in pain, being handled, having electrodes attached, and being forced to wear a hat in a strange enclosure. While the researchers selected cats for their behavioral compliance, the impact of stress on cortical dynamics cannot be overstated. To extract the pain signal, they used the PQ algorithm, which relies on a mathematical process called the Hilbert transform. In simple terms, this transform takes the real-world, fluctuating brainwave signal and converts it into a complex analytic representation. This allows them to calculate the envelope of the signal, which reflects its instantaneous amplitude. The algorithm then looks for the coefficient of variation within that envelope over 1-second sliding windows. The theory, transferred from human studies, is that higher fluctuations in certain frequency bands, specifically the gamma band, correlate with higher pain intensity. In this study, the magic number was 10%. If a cat's peak score in the gamma band of the central electrode, known as C, was 10% or higher, they were considered to be in pain. The results seemed to bear this out. The 2 pain-free cats had scores below 10%, and the 2 cats with osteoarthritis had scores above 10% in both conscious and sedated states. The ambiguous cat, number 5, was above the threshold while awake but fell below it when sedated. But here is where the story gets complicated. When we look at the broader world of neuroimaging and chronic pain, the picture is far from clear. Just last year, a massive study published in eLife by Gil Avila and a team of German researchers evaluated the exact same concept in 149 humans with chronic pain and 115 healthy participants. They looked at the aperiodic component of the power spectrum, a different but related measure of brain activity, often used as a proxy for the balance between excitation and inhibition in the brain. Their conclusion was a scientific bombshell. They found robust evidence against any difference in these brainwave components between people with chronic pain and healthy individuals. Even more startling, they found no correlation between these brain signatures and the actual intensity of the pain reported by the patients. They performed a multiverse analysis, running the data through 48 different methodological combinations, and the result was always the same: nothing. So, we are faced with a profound contradiction. On one hand, we have a human study with over 260 subjects that says brainwave analysis does not differentiate chronic pain. On the other hand, we have a feline study with 5 subjects that says it does. As scientists, this should make us lean heavily into the skepticism. Why would a signature that is invisible in a massive human trial suddenly become clear in a tiny group of cats? One possibility is the frequency band being measured. The feline study focused on the gamma band, which sits between 30 and 70 Hz. Gamma oscillations are known to be involved in the cortical integration of sensory information. But gamma waves are notoriously difficult to measure with surface electrodes because they are easily contaminated by muscle activity, known as electromyography artifacts. While the researchers used a preprocessing pipeline to remove these artifacts, any residual muscle tension from a stressed cat could easily bleed into the gamma range, potentially inflating the scores. Another major point of scrutiny is the use of dexmedetomidine for sedation. Dexmedetomidine is an alpha-2 adrenoceptor agonist. It works by inhibiting the release of norepinephrine, which produces sedation, anxiolysis, and crucially, analgesia. In the feline study, the osteoarthritic cats still showed high pain scores even under this sedation. The researchers interpreted this as proof that chronic pain has a persistent cortical signature that remains even when the animal is seemingly comfortable. But this interpretation is a double-edged sword. Dexmedetomidine is known to modulate gamma activity and thalamocortical connectivity. It does not just relax the cat. It changes the very neural symphony the researchers are trying to record. The fact that the ambiguous cat's score dropped below the threshold under sedation suggests that either its pain was acute and therefore responsive to the drug's analgesic effects, or that the sedation simply suppressed the very signal they were looking for. Using a drug that is itself a potent analgesic and a modulator of brain waves to study a pain signature is a methodological minefield. Furthermore, we have to look at the correlations presented in the feline study. They found a strong negative correlation between the peak scores in the gamma band and the paw withdrawal threshold. In other words, the lower the cat's threshold for pain, meaning the more sensitive they were, the higher their brain's pain score. At first glance, this seems like powerful confirmation. But when we look at the other indicators, the correlation disappears. There was no statistically significant association between the brain scores and the functional impairment measured by the Montreal instrument. Nor was there an association with the response to mechanical temporal summation, which measures spinal sensitization. Why would a brain signal correlate with a paw withdrawal reflex, but not with the cat's actual ability to walk or its spinal sensitivity? The researchers suggest that the paw withdrawal threshold involves more cortical integration than a spinal reflex, which is true, but it also suggests a potential for bias. If the peak score is only correlating with one of several established measures in a sample of 5, are we seeing a true biological link or just a random statistical alignment? Let us return to the human side of the scandal. The Gil-Avila study highlighted that chronic pain is a network phenomenon involving multiple brain areas, yet even a whole brain analysis failed to find a reliable signature. They suggested that the excitation and inhibition imbalances in chronic pain might be too subtle or too heterogeneous to be detected at the scalp using electroencephalography. If that is true for humans, why would it be different for cats? Are we suggesting that feline brains are simpler, or that their pain is somehow more uniform? Or is it more likely that with only 5 subjects, the feline study lacks the statistical power to see the noise that drowned out the signal in the human trials? We must also consider the limitations of the technology itself. Surface electroencephalography provides a non-invasive way to monitor cortical dynamics, but it is like trying to understand the conversations at a crowded cocktail party by standing on the roof of the building with a microphone. You can hear the roar of the crowd, but the individual voices are lost. The peak algorithm tries to find the rhythm in that roar, but when the crowd is only 5 people, every cough and every rustle of clothing becomes a major event in the data. The researchers in the feline study are transparent about these limitations. They emphasize that their work is exploratory, a first step toward a potential future where a simple wool hat-based test could be used in routine veterinary practice. They envision a tool that is objective, non-invasive, and inexpensive, helping veterinarians move beyond the subjectivity of behavioral observation. It is a beautiful vision. Imagine a world where Oliver the cat can tell his doctor exactly how he feels without having to hiss or hide. But the bridge from a proof of concept with 5 subjects to a clinical tool is a long and treacherous one. To get there, we need larger, more diverse cohorts. We need to account for age, as we know that brain waves and pain modulation change as animals grow older. We need to understand the influence of sex and genetics, as we see in human conditions like burning mouth syndrome, which primarily affects women and involves complex increases in pain facilitation, rather than a simple loss of inhibition. In the context of feline medicine, we must also ask how this new brainwave analysis compares to our current best practices. The 2024 study on Firocoxib showed that by using a combination of the Montreal instrument and objective measures like actimetry, which uses collar-attached sensors to track a cat's movement 24 hours a day, we can already get a very good sense of whether a cat is responding to treatment. Actimetry, in particular, is powerful because it measures the cat in its own home, away from the stresses of the clinic. Does a 5-minute recording of brain waves in a wool hat provide more useful information than a week of movement data from the cat's living room? Moreover, the Firocoxib study introduced the idea of cluster responses. They found that cats with moderate to severe functional impairment responded differently to medication than those with mild disease. Specifically, the more severely affected cats had a remaining analgesic effect even after the drug was stopped, while the mildly affected cats experienced a negative rebound effect where their pain seemed to worsen once the treatment ended. This kind of nuanced understanding of pain levels is where the real future of personalized feline medicine lies. If electroencephalography can eventually be refined to identify these clusters, to tell us which cats will experience a rebound and which ones will have a lasting recovery, then it will truly have earned its place in the clinic. But we are not there yet. The Delsart study is an intriguing piece of the puzzle, a daring attempt to translate human technology into the feline world. But it sits in a precarious position, sandwiched between the history of our clinical struggles and the massive, conflicting findings of human neuroscience. It is a reminder that in science, the most exciting results often require the most intense scrutiny. We want to believe in the painometer. We want to believe that the black box of the feline mind has been cracked open. But as we look at the data, at the tiny sample size, and at the confounding effects of sedation and stress, we must proceed with caution. As we conclude this deep dive, let us return to Oliver. He is back home now, his wool hat a distant memory. He is still sleeping a bit more than he used to, and he still avoids the kitchen counter. His veterinarian has started him on a personalized plan, perhaps involving a specialized diet, environmental adaptations, and a safe, long-term analgesic. We might not have a perfect brainwave signature to guide us, but we have decades of observation, refined clinical tools, and a growing understanding of the neurobiology of sensitization. The search for the feline pain signature will continue. Researchers will likely follow the lead of the human studies, looking at larger groups and using more sophisticated multiverse analyses to ensure their findings are not just statistical artifacts. They will continue to refine the geeky algorithm and explore other proxies for excitation and inhibition. And perhaps, in another decade, we will be back here, discussing a truly validated, routine tool that has changed the face of veterinary medicine. Until then, we must rely on our eyes, our hands, and our hearts. We must listen to the silent language of the cats in our care, recognizing that even when the brainwaves are ambiguous, the suffering is real. Science is a journey of 1,000 small steps, and while the path to objective pain measurement is steep and winding, every study, no matter how small, brings us a little closer to the truth. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.